Two patients walk into your office. Both feel hopeless. Both have low energy. Both say they're depressed. But one has major depressive disorder, the other has bipolar disorder. And if you treat them the same way, you could make one of them significantly worse. Let's talk about how to tell the difference.
That's actually a little scary when you think about it. Two patients can look almost identical at first glance, but the diagnosis and the treatment can be completely different.
Exactly. And that's why mood disorders are such an important topic. They're not just about making the right diagnosis. They're about recognizing patterns, assessing safety, and choosing the right treatment. And if there's one thing I want you to remember from this discussion, it's this. Always think about suicide risk, and always screen for bipolar disorder.
So, when we say mood disorders, what are we really talking about?
For today's discussion, we're focusing on the two major players, major depressive disorder, MDD, and bipolar disorder. And one of the most important questions in clinical practice is this actually depression? Or is this bipolar disorder presenting as depression? Because that distinction changes everything.
Let's start with depression. What does a classic patient look like?
Picture a patient sitting across from you in clinic. They tell you, I don't feel like myself anymore. They're exhausted. They're struggling at work. They've stopped enjoying hobbies. They're withdrawing from friends and family. And even simple tasks feel overwhelming. One way to think about depression is as a global shutdown of the brain. Low mood, low energy, low motivation, low interest, low everything.
That makes sense, but lots of people go through difficult periods in life. How do we know when it becomes major depressive disorder?
Great question. Two things have to be true. First, the symptoms must last at least 2 weeks. And second, they must cause functional impairment. In other words, the symptoms are significantly affecting the person's ability to function in daily life.
And this is where the SIGECAPS mnemonic comes in, right?
Exactly. But instead of memorizing letters, picture the patient. SIGECAPS stands for a pattern of symptoms that often occur together. The patient can't sleep. Or maybe they're sleeping all day. They've lost interest in activities they used to enjoy. They feel guilty about everything. They have no energy. They can't concentrate. Their appetite has changed. They're moving noticeably slower than usual. Or sometimes they're restless and agitated. And in more severe cases, they're thinking about death. When you see that cluster of symptoms together, MDD should move high on your differential.
So, if someone has more than 2 weeks of low mood, loss of interest, and worsening function, depression should be high on the list?
Absolutely. That's one of the classic presentations. But once you've identified depression, the next step is something even more important. Assessing safety.
Let's talk about that. Because suicidal thoughts are something that makes a lot of clinicians nervous.
And appropriately so. Imagine a patient says, I wish I were dead. Or, I wish I wouldn't wake up. Those are passive thoughts of death. They're serious and deserve careful evaluation. But depending on the overall clinical picture, outpatient treatment may still be appropriate.
So, what changes the situation?
Plan and intent. If a patient has a specific plan and intends to act on it, safety becomes the immediate priority. At that point, hospitalization may be necessary. And that's one of the most important principles in psychiatry. Diagnosis matters, but safety comes first.
Now, here's something I've always wondered. How do you avoid overdiagnosing depression? Because not every sad patient has MDD.
Exactly. And that's where the differential diagnosis becomes important. Let's start with persistent depressive disorder, also called dysthymia. Think chronic, think mild, think symptoms lasting at least 2 years. These patients are often depressed for so long that the low mood feels like part of their normal life.
So, less severe than major depression, but much more persistent.
Exactly. Now let's talk about another diagnosis that often causes confusion. Bereavement. Imagine someone who recently lost a spouse, parent, child, or close friend. They're grieving. They're tearful. They miss that person constantly. And sometimes they even report seeing or hearing the deceased.
Wait, seeing or hearing the deceased can still be normal grief?
It can. And that's a really important pearl. The key clues are that there's no severe functional impairment, no persistent suicidality, and symptoms gradually improve over time. Grief is normal. Not every grieving patient has major depressive disorder.
What about adjustment disorder? That seems to come up all the time.
It does. Picture someone who recently lost a job, went through a divorce, or experienced another major life stressor. Symptoms develop within 3 months of the stressor. They're clearly distressed, but they don't meet full criteria for MDD. That's adjustment disorder.
Okay, now let's get to what you call the biggest trap, bipolar disorder. Why is this such an important distinction?
Because bipolar disorder often presents as depression. A patient comes in with low mood, low energy, poor concentration, and loss of interest. It's easy to stop there and diagnose major depressive disorder. But before you do, you need to ask one critical question. Have they ever experienced mania?
Why is that question so important?
Because if the answer is yes, you're no longer dealing with MDD. you're dealing with bipolar disorder. And missing that diagnosis can lead to treatment mistakes.
You're talking about antidepressants triggering mania?
Exactly. Giving an SSRI alone to a patient with bipolar disorder can trigger mania. That's why bipolar screening should be routine whenever you're evaluating someone with depressive symptoms.
So what does mania actually look like?
Picture someone who hasn't slept for days, but somehow feels amazing. They're overflowing with energy. They're talking nonstop. They're making grand plans. They're taking risks. And they feel unstoppable. A useful mnemonic is DIGSFAR. Distractibility, insomnia, or more accurately, a decreased need for sleep, grandiosity, pressured speech, flight of ideas, increased activity, and reckless behavior.
So the patient who suddenly spends thousands of dollars, sleeps 2 hours a night, and decides they're going to become a billionaire by next month?
Exactly. That's the pattern.
And how do we distinguish Bipolar I from Bipolar II?
For Bipolar I disorder, just one manic episode is enough for the diagnosis. Depression is common, but it's not required. For Bipolar II disorder, patients experience both hypomania and depression. Hypomania is milder than mania. It lasts at least 4 days, doesn't cause severe impairment, and doesn't require hospitalization.
Once we've made the diagnosis, how do we think about treatment?
For MDD, first-line treatment is an SSRI. Other options include an SNRI and Bupropion. But one thing patients need to know is that antidepressants take time to work. An adequate trial is generally about 6 weeks.
That's another thing patients often find frustrating. They start a medication and expect to feel better in a few days.
Exactly. Setting expectations is important. Another important pearl involves side effects. The most common side effect that leads patients to stop the SSRI is sexual dysfunction. If that becomes a problem, switching to or adding bupropion is often a reasonable strategy.
Let's talk about ECT, because I think a lot of people hear electroconvulsive therapy and immediately imagine something extreme. When should we actually be thinking about it?
Probably earlier than many people realize. ECT is one of the most effective treatments we have for severe depression. Think about the patient with severe depression and psychotic features, the patient with catatonia, the patient who is not eating or drinking, or the patient at very high risk of suicide. ECT can be life-saving.
And there's another pearl people often forget. ECT is safe during pregnancy.
Exactly. That's an extremely important point.
You mentioned catatonia. Most people associate that with schizophrenia.
And that's a common misconception. Catatonia can occur in both schizophrenia and mood disorders. That's a very important association to remember.
What are some other high-yield patterns clinicians should recognize?
One is pseudodementia. Depression in older adults can sometimes look like dementia. Picture an older patient who constantly complains about memory problems. But when you actually test them, they don't seem to put forth much effort. That's the clue. The underlying problem may be depression rather than a neurocognitive disorder.
And what about seasonal affective disorder?
Another classic pattern, winter depression. Carbohydrate cravings, hypersomnia. When daylight decreases, mood worsens. And light therapy can be very effective.
Before we wrap up, what's one final mistake you want listeners to avoid?
Assuming every depressive presentation is psychiatric. Always ask yourself, could this be bipolar disorder? Could this be hypothyroidism? Could this be substance-induced? Could there be another medical explanation? Maintaining that broader differential helps prevent diagnostic errors.
So let's put everything together. Major depressive disorder, at least 2 weeks. SIGECAPS, functional impairment.
Passive thoughts of death require careful assessment, but plan plus intent should immediately raise concern for safety and possible hospitalization.
Persistent depressive disorder. Milder symptoms, at least 2 years.
Always rule out bipolar disorder before treating depression.
And SSRI is first line. Expect about 6 weeks for a full therapeutic trial. And remember sexual dysfunction as a common side effect.
ECT for severe depression, psychotic depression, catatonia, patients who aren't eating or drinking, and patients at high suicide risk.
Bipolar I requires one manic episode. Mania is DIGSFAR.
Bipolar II is hypomania plus depression.
And bipolar disorder should generally be treated with mood stabilizers, such as lithium or Lamictal, depending on the clinical situation.
And one final pearl. Do not treat bipolar disorder with antidepressant monotherapy.
And the big takeaway? If the patient is low, ask how long.
If the patient is high, ask how dangerous.
And if the patient is suicidal, safety comes before diagnosis.
That's the pattern. When you recognize the presentation, understand the underlying physiology, and know the key management priorities, this diagnosis becomes much easier to identify in clinical practice. Thanks for listening. If this review helped simplify a difficult topic, consider subscribing for more high-yield medical education content, and let me know in the comments what topic you'd like covered next. Until next time, keep learning, keep growing, and keep expanding your horizons.